talk is from Sarah Lundell from the Sahlgrenska University Hospital in Sweden and Zella King from University College London. And their talk is titled Enhancing Patient Flow, Real-Time Prediction at a Swedish Emergency Department. So welcome to the stage, Sarah and Zella.
Thank you, Claire. Okay, great. So yes, hi, my name is Sarah Lundell, as Claire mentioned, and I am a data scientist from the AI Competence Center at Sahlgrenska University Hospital here in Gothenburg, Sweden. And today I'll share our collaboration with the Clinical Operational Research Unit, CORU for short, at University College London. And together we've been working on enhancing patient flow in the emergency department using real-time prediction. And I also want to mention this is a project funded by the Swedish Innovation Agency. So this project began when two clinicians from the emergency department at our hospital asked my team, could artificial intelligence possibly help us manage unplanned emergency patient visits? So the emergency department at Sahlgrenska faces daily challenges securing beds for inpatients, as many wards are already operating at or near capacity. So we realized the key was predicting inpatient inflow, which for the last years has accounted for roughly 20% of patient visits to the emergency department at our hospital. And building on that insight, we asked ourselves, what if we could also predict where patients needed to be admitted to? Because this would provide a clearer data-driven view of the pressure on the emergency department, making the problem more tangible in numbers. And in turn, it could strengthen shared understanding and enable more proactive collaboration with the wards. So we began our external monitoring and came across an article by Zella King, who's joined me here today, and her colleagues, which was on predicting hospital admission for emergency patients. And Zella had presented this work as HACA 2023, actually. So intrigued by their approach, we reached out and arranged a meeting to learn more. And that is when Zella shared that the research had led to an open source Python package. So we saw an opportunity to apply it in our context at Sahlgrenska. And that marked the beginning of our collaboration. So we set the wheels in motion on a project to assess whether the tool could work with our data and evaluate the performance in our setting. So the collaboration began when CORU visited us at Sahlgrenska in November last year. And as part of this project, we have had 2 extended trips that has given us a great opportunity to work hands-on together. And the first trip took place in February, lasting about a month. And then there was a second trip in May-June, lasting approximately 2 weeks. And in between and afterwards, we have continued to collaborate remotely. So we could say that the work has been organized around 2 main phases. The first phase of the project was all about cleaning and preparing real-time data from our Elvis system for the pipeline. And getting to grips with the emergency department's processes was crucial for interpreting the data accurately. And the second phase, we applied the same approach at Zella had done at University College London Hospital, using the Python package to train our own predictive models. And finally, we used the built-in tools in the package to assess the performance in our setting. So now we can produce our own predictions for bed demand for patient inflow through the emergency department, much like at University College London Hospital. So over to some lessons and insights. One of the biggest insights was that despite using different input variables and achieving what seemed like having different input variables and having what seemed like less detailed data, we achieved predictions comparable to CORU using the same setup. And this slide shows the different groups of variables used at each hospital setting. And as mentioned earlier, we thought that our data at Sahlgrenska was less detailed. And some of these groups you can see contain only a handful of variables compared to what CORU used. So one of the biggest challenges was recreating unfinished visits with the completed data that we had to simulate a real-time scenario for the models to train on. We needed data that remained static throughout the patient's visits, or where updates did occur, that those updates also were retained. And what we did discover was that some data hadn't been stored in this way, and in some cases, certain data points weren't saved at all, possibly because they weren't considered relevant at the moment and not worth retaining for future use, or only relevant for the moment, sorry. So unfortunately, this made it impossible to use some of the data that we intended to in the beginning. So continuing on this comparison for similar models across the different settings at Sahlgrenska and UCLH, these Shapley plots illustrate which features had the greatest influence on the model's predictions. And as expected, age ranked highly in both settings, but beyond that, the feature importance varies between the two contexts. Our main takeaway was that understanding process differences really shaped our approach. Whilst our hospitals share many similarities and face comparable challenges, we uncovered notable differences in how we operate today. For example, we observed variations in patient management across the emergency departments, and one element of the package didn't fully align with what Sahlgrenska's practices were, which led to different care pathways and waiting times. But due to the close nature of our collaboration, we were able to provide direct feedback. So in response, Sella introduced an alternative solution, making the package more flexible and broadly applicable across sites. And we think this adjustment was a significant outcome, since it helped generalize the solution for wider use. So that is just one example of the impact this project has had. And here are a few more examples. After completing the project, we tested the predictions with an ED clinician over 2 days. And this trial sparked an interest in running a longer pilot, which we are now exploring. And in November this year, CORU returned for a visit, which was a highlight for us. And together we presented the project at several Swedish hospitals across the country. So that was all for me. Stella, did you want to add anything that I might have missed?
Oh yeah, thanks, Sarah. That was perfect. Just to reiterate, I think Sarah said that the process of working together enabled some improvements to the package, which was so true, because I had to really think what I'd implemented that was very specific to the NHS or to UCLH, and then what was actually very generalizable. And the amazing thing was to discover that despite Sahlgrenska having very different data flowing in real time, we were still able to get models that performed well to predict any given patient's probability of admission, and then aggregate that to predictions for each of the specialties that Sarah showed. So it was just really cool to be able to see this implemented on another site, and to see also that this could transfer internationally. So yeah, it's been a really exciting project. Very happy. And just also to reiterate that I think you saw my HACA talk from 2023 because it was available, and you contacted me after that. So this is, massive credit to HACA for inspiring this collaboration.
Definitely. Well, thank you then.
Wow, thank you both so much. That was a really beautiful story of working together, collaborating, and how kind of a good working relationship has helped you kind of generalize that model and made it work in another setting really well. So that was really nice to hear. Thank you very much. Please do post questions in the Q&A if you have any for Zella and Sarah. But I will. I'll just start by, if I may, it's probably more of a comment really, but obviously in the NHS we're very focused on our own problems and looking inwards and diagnosing what our problems are and trying to troubleshoot. So it's really nice to see this international example. So perhaps this is to Zella, kind of what do you feel that the value is of doing this international project?
So one of the things that really was striking for us was how many of the problems, as Sarah said, were very similar in terms of capacity problems, in terms of that causing overcrowding. And so to see, I think we maybe idealize Scandinavia in this country sometimes, but to understand that actually this is a problem for many developed economies, and the pressures on healthcare services were really similar. So it was just really useful to understand that, but also to see that a solution that we've created in the NHS, with the NHS issues and pressures in mind, could apply, could be extended elsewhere. We did have to make some modifications, as Sarah said. Part of it was to do with making sure the package could accommodate different data types. And then part of it was also thinking, we have a very explicit 4-hour target in England for ED admissions, and that wasn't necessarily appropriate. So sort of finding other ways to represent demand in terms of how long it would take people to be processed through the ED. That was another really useful aspect of working with Sarah and her colleagues.
Yeah, thank you. And I guess where next with this piece of work?
Do you want to say just a bit about the deployment questions you now have, and Sarah, and then
We have at our, as I mentioned, we're assessing if we could do a pilot in our, in the ED. So we're excited about that. But I think it will be, if you want to say something about your extended work, Zella.
Yeah. So just on the deployment thing, I think the project for Sahlgrenska was very much like, can we replicate this? And here's a proof of concept. So we've managed to get something deployed at UCLH. So now some of the conversations are amongst your colleagues, sort of how this application might be deployed such that you could have a full-scale pilot, and really put this in front of users to see how they like it and what they would want differently from it. On our side, Sarah just organised an amazing week in Sweden where we visited Sahlgrenska in Gothenburg, but also 3 other hospitals in Stockholm and Lund and Halmstad. And it was just great to be able to go together and talk about where the work began, and then talk about the fact that another hospital has implemented it, because we could start to sort of build a story about the generalizability of what we've done here. So yeah, it's kind of exciting. We're looking forward to what happens next.
Yeah, brilliant. We'll be, I'm sure we'll all be eagerly keeping our ears and eyes peeled to see what happens next with implementation. Thank you so much. We'll wrap up. Oh, sorry, I think we might have had a question drop in. I'll just ask that one. So from Jack, what did you each learn about the Others Health Service that you would see as learning for your home country?
I think it was what Stella mentioned, that there are a lot of similarities. So I think we can work together and do more of these kinds of projects. And I thought that was really, insightful.
Yeah, exactly. The sort of the challenges are similar, but some of the solutions can as well. There are a couple of questions in the chat, actually in the attendee chat. Have we got time just to answer those?
Yes, I didn't spot those. Thank you.
Yes. Do you want to read them out and then?
I will do my duty. So, what's been the interest from management in this? Has it been difficult to push through, or has it had a lot of backing?
Would you like to answer that first from your side?
From my side, the project in itself, I think, was perceived as a very most people were very excited due to that. It was we were able to try a solution that had been implemented and that there was a lot of effort behind. So in that sense, for our team, we got positive feedback doing this project and starting it. And now we'll see with the pilot where it will end up, I would say.
Yeah, and it feels like when we were there last week, it felt like we had a conversation with someone quite senior who was interested in your hospital, who was sort of just interested to understand it as part of there's someone involved in a change program where the how the EDs are organized might change. It was really nice to see that you've captured the attention of ED clinicians, web managers, senior individuals, and also technical people. So it's very cool to see it kind of spreading through Sahlgrenska, through your efforts. And I think in UCLH, a lot of our success is due to the support of people like Alison Clements, who I presented at HACA 2024 with, who's the Director of Operations at the Coordination Center in UCLH, and just really, they've stayed very loyal to the application that we've developed and continue to use it. Yeah.
Thank you. One final question from Peter asking, have any other NHS Teams organisations done the same? I think we've talked about that in terms of kind of where implementation and rollout is going next, but an important question on how do we generate more sharing or adopting behaviours?
Yeah, so on the first thing about other NHS teams, so at the R Python conference a couple of weeks ago, I did have a conversation with a couple of other hospitals who may be able to adopt something. So yeah, watch this space on that one. So that's really exciting to think that we might be able to spread this inside the NHS a bit. I think in terms of how we encourage more sharing, obviously, I don't need to say this community, open source and reproducible pipelines are a massive help. And it would have been really different if we hadn't gone down that route in terms of working with Sahlgrenska. So yeah, big plus for RAP. And I think just talking about what we're doing and trying. I'm aware that this is not an easy aspect of using real-time data for predictions. It's tricky to get the data ready to do it. So the more I can share and others can share about how to do that, I think is through platforms like this, the better.
Wow, thank you. Yeah. On that note, we'll wrap up. Thank you again so much.